Welcome to the latest episode of the Melbourne Athletic Development Podcast. Today, we are extremely lucky to have Dr. or is that Ms. Sarah O'Reilly Harbage. Sarah, can you give us a little bit about who you are and what you do and maybe why I gave such a bit of a weird intro there?
Absolutely. So my name's Sarah. I am an orthopedic surgeon who has a subspecialty interest in complex arthroplasty, limb salvage, and sarcoma surgery, which makes me a bit of a unique beast. There's about 20 or so of us around Australia that do that sort of work as our predominant practice. I was born and raised in Brisbane, trained in New South Wales with a touch of the US and then fellowed in UK. Moved to Melbourne. So as I was telling you guys earlier, that means my only retirement plan is to move to Tassie because I'm slowly working my way down the coast of Australia. But yeah, it's a great career option. It's taken me everywhere. With regards to the title issue.
Yeah, we were talking about this before. For those who don't know, generally, traditionally, surgeons have gone by Ms. or Mr. rather than Doctor as their designation. But why is that? Because you're obviously all trained as medical doctors to start with, but you've actually suggested that's slowly changing as well. Can you give us a little bit of background on what's going on there?
So historically, doctors were people who trained to become physicians.
Yes.
If you look back in history, back when you were looking at the Navy and things like that, before we had the structure that we have now, you actually went to your barber to have your operations done. So because
I still go to my barber to get my operations done.
Completely reasonable option at times. But so because they were good with a cutthroat, they would do things like appendectomies. So obviously they weren't trained as doctors. That was a barbering apprenticeship, so they were known as Mr. So historically, that's where it stems from, that you were a barber surgeon, not a physician. So there is the Barber Surgeon Hall in London, which is where the original craft group of surgeons were based. And I've got a photo of that with me and my partner when I was on fellowship there, because my partner actually is trained as a barber. So I joke that we're a very conventional couple in the sense that we're a barber surgeon couple.
Fantastic.
He taught you the skills, did he?
Obviously.
And you're saying that's now changing?
Yeah, so I think because historically it was very much a male-dominated area, the whole Mr. Ms. thing became a bit controversial. We are all medically trained, and there has been issues in the past of people maybe not recognising that female surgeons are surgeons and sort of identifying who they are within the team and our role within the group, although I don't often find that the case now. So the sort of overarching title that we use now is doctor, or moving through, your professorships and things like that. So they've sort of standardised it.
It's always interesting because, we refer a lot of people to surgeons, and the first thing they'll say, why is the documentation actually not say doctor? And you have to kind of explain. I obviously don't know the history at the same level that you do, but, well, that's actually the designation they go by. It doesn't mean they're actually more trained than in many respects.
It's a really interesting thing. So doing my fellowship in the UK, so when the junior doctors sit their first surgical exam and they get awarded their MRCS, they all transition to being Mr. or Ms. at that point. So it's actually a real point of pride for them.
Yes, yeah.
So I guess, for people who associate with that point of pride for them, that's their achievement, is converting from being, before you do medical school, you're Mr., then you become doctor, then you become Mr. again, or in my case, Ms., Dr. Ms.
Yeah.
And that's a big achievement, but I think it is very confusing for people outside our little world where that's important.
Shifting into your very interesting area of practice, can you explain a little bit about what, you mentioned limb salvage, you're obviously trained in trauma and orthopedic type surgeries. Can you explain what you do and some of the surgeries that you are involved in? You obviously mentioned sarcoma as well, so we might go down that path at some point.
Absolutely.
But explain a little bit about that, because as you said, there's not many people who do this, and we thought it was super interesting to have you on to speak about it.
I really appreciate that. We're a unique little craft group within the orthopedic community. There's probably about 1,500 orthopedic surgeons in Australia, and there are people who do big complex revision work that goes beyond our group, but we're probably the core group of about 20 or so. We have an interest in complex patients who have reached a point where, the limb is either going to be saved or we're looking at something like amputation. And that can be for any range of reasons. Like on a day-to-day basis, I can do something as simple as fixing an ankle. But on my big days, we're looking at patients who either have cancer of some description, they've had major trauma in the past, or they've had joint replacements that haven't gone so well for various reasons. And they're sort of looking down the tunnel of, well, the standard orthopedic surgeon is now maybe at the limits of what they do and what they're comfortable with and what their training is. And then there's those of us who have gone and looked into things like mega prosthetics, which is when you're talking about big segment resection. So, on an average day, I might take out 24 centimeters of someone's femur and replace it with metal and plastic, essentially.
Hey, what's the path to get into this? Because is it something that you have interest in? Is it something that you show aptitude in? Is it something that you go, I actually really like these very complex problems?
Yeah.
Like what draws someone to this? Because I don't suspect that everyone's jumping at the opportunity to cut, a quarter of someone's leg off.
No, there's certainly not. I think you've kind of nailed it in that sort of, you have to truly enjoy it, and you do have to enjoy this job. It's something you've got to be really passionate about.
Yeah.
It's not easy on a day-to-day basis, but it's hugely rewarding. I think you have to be interested in the fundamentals of what you're trying to achieve for a person. So for me, the AOA talks about the wonder of movement, and that's what we all want to achieve as orthopedic surgeons. The question is
AOA.
The Australian Orthopedic Association. It's their little mantra. I'm big on acronyms, and I apologize. But it's this thing where, I was always drawn to the slightly more complex patient that posed challenges in how we would approach them, both as a patient and what we can do for them, but also often their background history is a little more complicated. It takes a deep dive.
What do you think is behind that? Is that a personal thing, or is that something that you want? Yeah, like when I say that, is that you wanted the challenge and you enjoy the lack of monotony that probably comes with that?
I think that's a very gracious way of explaining why I do it. I think I am a very simple person who doesn't understand an awful lot compared to the average orthopedic surgeon.
I'm sure you do.
I
don't say that. People won't be coming for their limb, reflection.
I imagine your 20 years of training would say otherwise.
Look, the way I see it is, I love a challenge. I love the process. I love the fact that it takes a lot of planning and discussion and teamwork to get us to a point where we can do something. I often work with other specialists. So last week I had a urologist and a general surgeon in theatre with me because where I'm working, it's a team sport. My anaesthetist is someone I trust deeply, who does a wonderful job and, helps keep the room vibe right. Like, we're big into that collaboration. And I think I was always looking for that next bit of challenge. Like, I started off really passionate about trauma, and I still am very passionate about that, because I think it's something where someone comes in, they've got a problem and I need to solve it. And I can't let them go until I have solved that problem for them or found the right person to solve that problem.
I think it's an interesting position to be in, because I feel like in healthcare, and it's probably in other areas of life as well, there are people who like taking on opportunities where there isn't actually an answer that you can go and look up.
Well, I was going to say, I feel similar, and that was a question I wanted to ask about.
Versus the people who they like sticking to the protocol of the exact kind of, this is what we do for this type of problem.
Yeah, and correct me if I'm wrong, because I'd make the assumption that for a lot of orthopedic surgeries, let's say a joint replacement, there's a lot of similarities as to the steps that are required.
You don't have to be too nice, Jack. I'm sure it's boring as hell to do 10 back-to-back, knee replacements.
As opposed to someone who has had trauma and you're looking at limb salvage approach, there is novelty to every case.
Correct. And I think, that's driven partly, like, where you find yourself within your specialty is driven by your personality and what you find joy in. If you're sort of a concluder producer type and you like the minutiae, like, then arthroplasty, ACLs, those things that require like deep finesse within it, is really important, that we have people who love obsessing over angles. Like, I've worked with guys who get a goniometer out and they measure their 70-degree angle, they set their ACL up, and they do beautiful ACLs. And there's 86 steps to an ACL, and that's how they do it. And they are masters of their craft, and they're very, very good at it. I do arthroplasty, and I have to go from this sort of minutiae, thinking about millimeter cuts, to do I take another inch of someone's bone? So there's big swings in how I philosophize about what I do.
Yeah, it's something that I think about quite a bit, because I don't know if Jack mentioned this at all, but I work across a few areas, in track coaching, and obviously I'm a clinician and sports performance stuff. But I tend to be, I think I'm really resonating what you're saying, because I slant towards what you are talking about rather than minutia. And I'm always interested in this, and I spend way too much time watching TV shows that And I'll openly admit that. But I love things like, I don't know if you ever saw the documentary on the Japanese sushi maker, Jiro Dreams of Sushi. And to me, that is my worst nightmare. Spending my whole entire life specializing in one thing. It's almost like what you were saying with the ACL surgeon. Like, they're so caught up in these are my 86 steps, and I'm so perfected in that. To me, the lack of novelty there scares me a lot. And I find it interesting that there is that differentiation, but also that more than anything, we should respect the fact that we have these different people in our profession, because we need some people who are pushing the development of an area versus the people who are perfecting what has already come before them. And neither should be respected more or less. It's just they're different, and we have to actually understand that those skill sets are valuable for healthcare.
Totally. And I think that's the thing. Like, I look at it as there are operations that I do that are very routine, that I have a very specific approach for, and I know that they will be reproducible. I know how I go about it. I can explain it to you. I can draw it. And I can explain every single step. And then I embark on that sort of limb salvage, trauma, and tumor side of things. And what you have to have is really good core principles. Because if you don't understand it, then you can't move forward when you're doing that case, because the anatomy is not what it should be. That's the whole point.
That's really, we love that you say that, because it's something that we harp on. So apologies to our listeners. But can you talk about some of this principles approach? Because it's something that Jack and I actually get into a lot of discussions, we're probably talking to ourselves too much, but about the fact that from a healthcare point of view, even in our training, we don't teach people principles as much as we should. We teach them protocols. So can you explain a little bit about your idea of how principles actually inform what you do, so that you're not sitting there going, uh-oh, that limb doesn't look exactly what the anatomy textbook said. What the hell do I do?
And I followed step 1. I should have to go to step 2 now, but this doesn't make sense.
So, I think there's this awesome textbook that every orthopedic surgeon memorizes when they're going through training. It's called Hoppenfeld, which is our surgical approach textbook. And that's an awesome textbook. You have to know it. You have to know it inside out. You have to know the variants. You learn all these things. It's about learning anatomy. But one of my great mentors always said there's no such thing as approach, there's only anatomy. And he's a big trauma guy. So that philosophy really resonated with me, in the sense of, like, it's all well and good to know that you should go between these two muscles, but what happens if those muscles aren't there?
That's the Mike Tyson quote, isn't it? Everyone has a plan until they get punched in the face.
Like, literally. So, and my job is to have a plan when I get punched in the face, and to be able to come out of it.
How do you train for that? What do you get thrown in the deep end? Is it these days? Is it a lot of simulation stuff, or is it you actually are in there and you're like, okay, I have to troubleshoot as long as the patient's stable. Like, I can navigate.
It's a graded thing. Like, my fellowship was amazing. I had such a good relationship with the team. It was really interesting. I got there and I was like, I'm too dumb for these people. I'm out of my depth. Like, this is Stanmore, which in the world of sarcoma surgery is like the place.
Yes.
People fly in internationally to have their sarcomas cut out by this team. Like, these guys are
cream of the crop.
Yeah, they're amazing. I honestly thought I'd show up and they'd be like, yeah, maybe not for you. You're fine. You're a solid surgeon, but this, but it felt like coming home. They felt like my people, which was when I realized that maybe this was something that I was going to deep dive on. And they sort of, a few weeks in, sort of kept guiding me towards doing more and more, and said, this is something that suits your personality and how you think.
Yeah, can you give us an example of what kind of things you were doing in that environment that did make you feel, okay, this is where I'm meant to be, but also how they kind of bring you along for that journey? Because it's a very different way of thinking.
Yeah, so there's two parts to that story. So the first part was I arrived and there was just this massive case they'd sort of done the first operation that was setting up, removing bits of bowel and ureters and diverting all of their urogenital tract to be able to then take the tumor out. So they'd had one surgery. So I rock up and my basically indoctrination into that theatre was the second surgery. And I think we went through about 40 or 50 units of blood that day. Wow. It was big. We're operating through a laparotomy, then we flip the patient over and we're doing stuff from the back. And we actually had to come back another day to get everything stable and out. Like, it was big surgery. So this patient went through like 3-4 surgeries just for their initial tumor removal. So you're talking stuff that's really pushing the boundaries of what one can achieve safely. And it was, as I said, multiple teams involved. It was huge surgery. And I felt like that was a really comfortable place to be. Like, I am not the person at that point in time to be leading that team, but
Yes.
I want to be here. I want to learn. I want to see how you guys work and how this dynamic works. And it felt like a great amount of camaraderie and a great amount of everyone focused on the best possible outcome for this one person.
Have you found it's hard to find that type of culture?
I think you have to create it, right? So, then it's baby steps back. I start taking it little tiny, like 1 centimeter, benign tumors, then they build you up to being someone who can tackle things like that.
I think, building on what Jack said, do you think it's a reflection of there is no opportunity to be overly confident in that type of surgical environment because the complexity will humble you at every
you will be
circumstance
at any opportunity. It's one of these things that you need, like I said, those fundamental principles, because when you get to a point where you're looking at it going, this is going to get tough, you need to know that the team around you is going to support you. They're going to call you out if you're doing something they don't think is a good decision. So you need a lot of faith and you need to flatten that hierarchy. And then you need to know that these are people who are going to get down there in the trenches with you and help you.
When things go sideways. Yeah.
And, I'm very fortunate. I haven't had too many things go seriously sideways. And every time it has, it's then about being able to make good decisions about things that aren't working out well to get the best possible outcome.
Well, and I was going to say, because I imagine in these types of surgeries, there's no necessarily right answer. It's about sort of justifying, I think this is the best approach because of
XYZ.
XYZ.
Yeah.
And I think it's a very different conversation to have, because I feel like in healthcare in general, there is this idea of this is the gold standard, this is how we go about doing things. But this actually throws that out the window of going, well, unless you actually are very adaptive and malleable to understand how you're going to address this problem based on the factors presented,
correct,
you're actually going to find that you don't have an ability to be responsive to what's going on.
Yeah, and you have to be willing to step back and look at what's going on from, like, it's like, for people who are more people are familiar with the sort of emergency situation where we go, DR, A, B, C, and when something's not going right, you go back to A again, right? So it's this, okay, that's not quite going right. We don't keep going down that rabbit hole. You have to actually step back, look at it, go, am I the right person to be making this decision? I talk to my team. Do I need to get another surgeon in another specialty or my specialty? Do I need to head check myself? So we work, even if you're a solo surgeon operating at one point in time, we try and coordinate so that there's someone else around when you're doing big stuff, because it gives you that sense of, hey, there's someone else who knows this sort of stuff, and if I get stuck, I've got people to draw on. I'm eternally grateful for the people who come and join me in theatres, because, a problem that 2 people are attacking is already a problem halved. The stress levels are right down when you know that there's people who've got your back and who have a similar goal to you. You have to have your head in the game. They need to understand where you're at, and that we're a very unique group of people who attack these problems.
I don't know why I'm so interested in the dynamic of this, but I tend to find, and I'm interested to know whether you have seen the same thing, but it doesn't matter what field I seem to look in or the people I seem to speak with. If you go to people who are taking on bigger and bigger challenges, they get more and more humble because they have been exposed to more and more difficult situations and environments. Whereas people who don't seem to want to take on those challenges get very arrogant about what they can and can't do. Is that something that you've observed? And I know I'm very much calling out a whole field, which I'll pay for it, I'm sure, in some way. So I accept that. But it just seems to be the case. It doesn't matter what field it's in. It doesn't have to be medicine. It's just that as soon as you keep talking to these people, like they're taking on, you're like, this is a really difficult problem or an interesting problem. It's got lots of steps. They are not overconfident in what they're doing because they're like, okay, I can see that there's lots of areas where there's a failure point.
Yeah, I think it's partly Dunning-Kruger, partly, if you practice, like if you want to talk about orthopedics, if you practice what we call champagne orthopedics, you do the really good stuff, and they do brilliant work that, gets people back to having great quality of life. And I respect what they do hugely. And I do some of that stuff. But if you're going to do operations that, have like a 30, 40% complication rate, and that's what the sort of numbers that we're talking for some of my patients. And I'm very upfront with them about that. It's something that we embark upon together, and you are going to be humbled regularly.
Yeah.
So
Is that, in some ways, is that scary, or have you become comfortable with that level of risk? As long as you said, you're communicating and there's a high level of, consent with that.
look, it's funny. The minutiae stresses me so much more than the
Okay.
big stuff
Yep.
these days. And
Just because of the precision required and
yeah, and I think it's just that evolution of what you're doing and what you're trying to give to a patient. Like when I do a younger person's total hip replacement, like I get someone who's in their 40s or 30s and they've got arthritis, I flip back into that, I'm worried about, is my cup sitting at 40 or 42 degrees? Is it millimeter perfect? Are they going to have the hip that I can let them go surfing or do yoga with at 3 months post-op? I inherently am stressed until I see that x-ray. I also took out the front part of a person's pelvis the other week, which took 8 hours. And I was equally stressed until I saw his post-op x-ray and knew he was okay. I think it's just, I worry about the patient that I've done a carpal tunnel on and make sure that they've got their symptoms resolved.
I imagine this is something John and I talk about a fair bit. It's that level of uncertainty because of the novelty, you're not sure of what the outcome will be until you see it.
Correct. And I think it's getting comfortable with the fact that that they're not going to be, particularly the big surgeries, they're not going to be 100%. It's not like you're going to do something and they're going to be like, oh, Sarah, this is great.
especially when you've cut their limb off.
Yeah. And to be honest, some of the patients that I've done the most complicated surgeries and even amputations on, like I do some really, when I think about it as a human being, some pretty intense things to people, and the faith they put in me and the grace and gratitude that they have shown me far outstrips, what I feel like I deserve. Like I am a humble bone surgeon who will do what is asked of me and what is demanded by their situation, and I'm willing to take that risk with them, but I'm taking it with them. And, when I've amputated someone's arm for cancer and they ask me if it's okay to give me a hug, I just think, of course,
that's the least.
That's amazing that you are willing to do this when I'm the person that's done this to you. I feel like I've taken something from them, whilst I respect the fact that the goal is to try and prolong their life and give them quality of life. The loss that they are suffering is so huge. The fact that they have the grace to think that I've done something good for them is so heartwarming. And
I think it's extremely heartwarming to even hear you say this, because we talk about this a hell of a lot. The issue with evidence-based medicine or evidence-based practice, and a lot of clinicians not understanding the clear definitions of what factors into that, and one being patients' values and expectations. And it sounds like you put that very much at the forefront of your practice, which is, as I said, it's extremely heartwarming to hear, because not only is it rewarding, it sounds like it's getting an extremely high level of beneficial outcome for the patient as well, which is, I guess, for all of us as clinicians, that's what we're trying to achieve.
Yeah, and I think, it's when you're getting into things where you are talking about some quite devastating outcomes for people, I spend a lot of time discussing quality versus quantity of life and what I can do. And then there's layered into that is a level of respect, particularly when you're dealing with the more intense side of things. Cancer brings out, lots of end of life and big life decisions for people and discussions. People's religious or spiritual components come into it, their beliefs around whether they will be able to go to their version of heaven or whatever, they believe in, if they have lost a limb, and, working through those processes, human identity. I do some surgeries that leave people with not the most cosmetic situation, and trying to give them a good cosmetic outcome is always part of it, but it's always obviously secondary to functional, ideally pain-free, and being able to move and be independent. So it's sort of, you're weighing up all of these things, and it can be huge identity shocks for patients. So you spend a lot of time moving around through the psychosocial, aspects of who they are and what they want and what we can achieve for them.
How does that affect you? And how has it affected or shaped you in terms of how you view these things? Does it change the way that you view what you want your life to be, or the decisions that you'll make with your health going forward as well?
Yeah, look, I think,
I know that you're a parent as well. So
yeah, look, I think it's really it's interesting, because I feel like I've gone through various evolutions of who I am as a doctor and orthopedic surgeon, because I keep, every few years you evolve into that next version of yourself. Like I said, I started with trauma, and then, I did arthroplasty, and then it kind of evolved into this tumor thing, which I'm quite far down the rabbit hole on now, and I really enjoy and I'm passionate about. But yeah, like in my personal life, I was I was a really keen rower. Then I started realizing that didn't fit well with being a med student, so I evolved into a gym junkie. I went through the bodybuilding into the powerlifting stage, and then I had kids, which I can tell you now humbles you, and takes a lot of time. Whatever time I haven't spent with my family, I spend with my patients, or if I'm not spending it with my patients, I'm spending it with my family. So, again, like that health thing, I'm slowly approaching, one of those milestone birthdays and thinking about that. And it's like, I've sort of put myself on the back burner to achieve these things for my kids and for my patients. And now I'm slowly rebuilding who I am as well. And finding that balance is really hard because it is a demanding specialty. The hours can be really long. Like I was out operating till 11:30 the other night. And then, I finished ward rounds at 8 o'clock last night. So my youngest was in bed by the time I get home. But they're the sacrifices you make, but then you have to find ways to make sure that you are present. Our family's a little bit interesting at the moment. My youngest is allergic to quite a number of things, and I refer to him as the carnivorous vegan because we can't have egg and we can't have dairy. So like Sunday mornings, I make waffle mix on Saturday night. We get up, we have vegan waffles, every Sunday at the moment, which is a really nice family time. And you try and build that in so that you develop that relationship and we can have that core values and try and give them those memories, even if mum isn't quite the typical mum who is home more often than
I guess
not.
the question is, and it's a different topic, but what is a typical mum anyway?
That is a very good point.
And it's, I think that's one of the things that is nice about the evolution of social structure is that I don't think we can actually say it's this or it's that. And it's unfair to almost do that anyway in today's day and age.
Well, but I think it's radically changing, actually, particularly on times.
Yeah, and like it's good because it also means it's rapidly changing for dads too.
Yeah, definitely.
Yeah, look, it's a completely different discussion.
We can go down that rabbit hole.
Well, it's up to you, but it's more that I think that more than anything, I think, as you said, I think if you're instilling good values into your children, and those principles, I think we see it as employers, right? Like we find it very interesting. Jack and I have some very interesting conversations at times because you see, like if someone comes from a place where their value structure has been developed, whatever their social and family situation was, their behavior endures those values. So it's kind of really nice to hear that you set aside time, even if it isn't all the time, to be like, no, spending time with your family is important.
Oh,
right?
Exactly.
And it's reflective of your professional practice and decisions you make as well.
Yeah. And I think that's it. Like more and more when I have discussions with patients and what I'm reflecting to them is that they should be spending that time with their family and not with their orthopedic surgeon, because there are times when that's exactly the conversation I'm having. It drives it home that, my kids are only little once and it's a balance. I'm always like the hard part is I'm always there for my patients. Like my phone just never gets switched off.
I think the good thing for me is my patients don't want to spend any more time with me. So,
but
a question I wanted to ask you is: you talked about how your own evolution and how specialization in a trauma, limb salvage, surgery has really made you appreciate and respect uncertainty, understand that complexity requires you to have an open mind with how you approach things. Do you think that's a quality that's missing a lot in healthcare in general? When you think about whether it's the medical field, like in a physiotherapy, do you think that's something that is not trained or appreciated enough?
Yeah, I think, the mantra of getting comfortable with being uncomfortable is hard for people inherently. And I think a lot of structures, and when I think it's sort of ingrained from even an administrative level. They like paperwork. They like to be able to tick box and go, yes, no, this is an absolute. Except that's not how it works. And the further down this you get, the more you realize that you are in potentially evidence-free zones or you need to work around things and things like that. So I think, I don't think a lot of people are comfortable in sitting in that uncertainty.
How is that evolving from a legalities point of view? Is it getting worse and worse for you guys to be able to get these things signed off, or is that something that you don't necessarily have to broach at a clinician level?
Oh, look, there's there's many layers to that. When you're looking at certain prostheses, there's certain ones we can use, there's certain ones we have to ask, there's a special form that I have to request, and it's because it's either not quite signed off in this way or that way, and there's many layers to that. There's certain things we can and can't do, but most of it is, we spend a lot of time in MDT, like multidisciplinary team discussions, or liaising with our colleagues to work through these very unique situations to see what kind of, for lack of a better term, pass the pub test. What would most of us do given these circumstances? Is what I'm thinking of doing safe, sensible, reasonable, and is it what is in the best interest of this patient?
Yeah.
And one of the other things I always think about is, what are all the things that can go wrong? And what am I going to do if any of those things happen? Like, what is my bailout? There's always a plan A to at least D on any of those big cases that I do.
I think the good thing with that, and I talk to people about this a bit, when you look at problem solving in general, I really quite often like, and it's not the same obviously because we're dealing with a much more complex system, but the way in which engineers tend to approach, failure points and understanding those failure points, you said, like having A, B, C, D. I remember, again, another documentary that I watched, but they're talking about the new telescope that went up, the James, I can't remember what it's called, the JWT telescope. Anyway, it's the one that got the first picture of the black hole, the event horizon. And I can't remember the exact number, but it was something like there was 150 or something like that critical failure points. And the head engineer is talking about the fact that like any one of these things goes wrong and the whole project just goes completely south. And it was such an interesting way of looking at it. As you said, rather than looking for all the way things go right, it's like, where can this go wrong? And do I have a plan for every single step when it goes wrong? And I don't know that particularly as a younger clinician, I ever thought about it in that way, because I was always like, no, these will all go in the right direction.
Yeah.
But now I think I often have a lot of backstops of, oh no, this could go wrong, this could go wrong, this could go wrong, because I've seen these things go wrong. What's my contingencies? Is that something that you've evolved to do more of, or is it something that's always been there because it's just kind of you're wired that way?
I think I'm a little wired that way, to be honest. But yeah, definitely. If you talk to me right before I do one of those cases, I sound like I'm doomsday prepping.
Yeah.
Because I'm like,
this.
Like, I'm just thinking that this could go wrong, this could go wrong, this could. And people think that you're getting down in the dumps, but actually what I'm doing is preparing myself. It's like prepping for sport, right? You're running the race before you do it. And what I'm thinking about is each hurdle that I'm approaching. Okay, when I hit this one, what happens if I knock that one down? How do I keep going? Or do I need to then step into someone else's lane?
Yeah.
What's the...
Well, I had this exact discussion with some friends of mine who they do come in for treatment, but I've got an athlete who is in preparation and she's a reasonably good chance to make the Olympic team, but there's about 5 different contingencies based on how we're actually going to make that qualification work. And there's some not overly complicated steps, but there's like, if this happens, we've got to do this, we've got to do that. And he was laughing at me saying like, yeah, so it's really straightforward then. And I was like, yeah, completely.
Well, I mean, if everything goes the way it should, it can be really straightforward. Like there are cases, whether it's, training someone, whatever, that if we hit all of these milestones and
it happens.
It happens and it looks like easy success, right? But sometimes, we talk about when we put x-rays up that look great in orthopedics, and this could be any sort of x-ray, it doesn't show the pain that you went to get to that point. And no one's ever going to know the suffering of that case because you as a surgeon will be there in the trenches until it is done and it's done right. And that's the thing, right? So you need to know that if they don't quite make this step, how am I going to get around that? Is there a way to like rehabilitate an injury or train them? Or is there another competition they need to compete in? Like, what is that next avenue that we find to try and get to that endpoint? Because the endpoint is where we want to be. How we get there can be a little creative.
You just mentioned that, and selfishly, you mentioned rehabilitation. So I'm selfishly going to ask, is it something that you guys think about, maybe not necessarily with something that's a bit more functionally difficult, say like some sort of limb salvage case, but for someone who is a bit more routine, are you thinking about what processes and steps they need to go through to rehabilitate something and what that looks like? Or I know that, for instance, we do a lot of work with ACL surgery patients, and something that's become really popular And some surgeons still do it, some don't. But have you seen like the lateral tenodesis they do for the joint to try and stabilize rotary function?
Mm-hmm.
And one of the surgeons that I have worked with quite a bit, he said, the main reason that I think this is useful is it takes stress off the actual healing graft during that process. Like he said, I actually don't care if it fails after about 6 months because most of the healing stuff is, and I thought it's really interesting. He said, like if I can protect it while it's being rehabilitated, it gives it an opportunity to heal nicely. I was like, okay, that's a really interesting way of looking at it. Is that something that you think of generally, or is it more like I need to get really good surgical alignment and I'm really happy with this and I don't care what happens after I've done my job?
No. Look, I think that, again, that's a philosophical question of who you are as a surgeon. Like, there are people who are like, well, I put the knee in, it looks good. If it doesn't work, that's on you.
I did my part, yeah.
Which, like, you take a patient on and you take a lot of responsibility for operating on someone. Like, I go in and it's another day at the office for me, right? This is my job. I should be calm. It should be like, it's just another knee replacement. It changes that individual's life for better or for worse when I do that operation. And, I hope we all carry the burden of the patients that don't have the outcomes that we were striving for them. And, working on what is it that I can do? How do I do that? How do I make sure they get the best physio that they can have? What did I close their wound with? Is there something that I should have changed? Like, you go back through and, I'm my own worst critic. I will pick everything apart to find if there's a failure step there.
Can I ask, is this a gender thing as well? I have noticed quite significantly, and this is very much anecdotal, but female clinicians tend to have much more of the slant that you're talking about. They care a lot about their patients, whereas not all, but some male clinicians are like, I did my part, so it's up to them. And we even have it even with our own stuff. Like, some people almost care too much, and you're like, you don't need to do that much. You don't need to be taking those calls or doing that follow-up, but they really do care.
Yeah. Look, is it a gender thing? I don't know. I mean, I practice the way I practice, and I know that I carry some of it probably, like a little bit more than I need to. The flip side is I am very good at putting that in a box when I am surgeon. Do you know what I mean? Like, for me, when I'm operating on someone, even though I know a lot about them, they become what I need to operate on, because I am not going to sit there and think that this is Mrs. Such and Such with 3 kids at home. That I can't do that. That's not me as a person. Once I'm operating, that is
It's a different
zone,
space.
and it's a different space. I think that's partly just, who you are as a person, and also maybe your motivations for why you're doing what you're doing. There are people who are very good technicians.
Yes.
They are very technically capable. Maybe they're not the best with the bedside manner side of things. And then there are people who are, that's probably their strong point. Maybe they're not so technically capable. And then there are people who maybe are both. But, I think every surgeon has capacity to be really good. And even if you have the best bedside manner ever, there's going to be patients that you just don't gel with or whatever. So I think it's a really complicated thing. And maybe gender has something to do with it. Maybe it doesn't. I'm not really sure. But I suspect that you probably see it a little bit more in the surgical specialties at the moment, because I know you've spoken to a few female orthopods. There's not that many of us around, so we probably stand out a fair bit anyway.
Well, the ones we have spoken to, and you're the third or the fourth female orthopod we've spoken with, you all have a very similar slant. And that's why I say this is like, it's a patient in front of you that's important. And I would say that, I don't think that there's any, well, it's not for even for us to judge of like your technical capability, but I don't think in any way from anything you said compared to other orthopedic surgeons that you're not at as high a level, if not higher. But it's very evident the difference in how you talk about that case and that individual. And as you just mentioned, whether that changes anything for one individual or multiple people, who knows? But it's just been interesting to observe.
Yeah, maybe we're better at verbalizing it as well.
True.
Because it's sort of just a societal expectation of how we function versus how men are meant to be perceived in their roles as surgeons. I'm not sure. I genuinely, I could deep dive on that for a while.
I know, because nowadays you look at medicine, there's more and more females who are graduating from medical programs and then males. And, it's obviously a generalization, but typically men are more interested in things where females are more interested in people. So it actually aligns with medicine and healthcare for more females to be in those professions because they are actually interacting with people.
That's very true.
We spoke closely, and we know her well, to Pam Bokel about this. But did you find going through the training that there was, limitations? She was quite strong on this, but saw it as a worthwhile challenge. Did you have issues with this, or do you think it's something that it clearly seems like it's changing from the conversations we've had? But is it something that you think is important to discuss, or these days is it just it's a moot point?
Oh, look, I mean, it's changed dramatically. Like, the landscape has changed dramatically since I first became interested in orthopedics. I kind of knew one female orthopedic surgeon, and I knew one trainee.
Yeah.
When I started, and when I was 19, I caught a train to a different town to meet the one female orthopedic surgeon I knew, because I kind of thought this is something I'm genuinely really interested in. After I'd seen a fracture clinic and a tibial nail, and sort of got my hands on some tools and a regional term, and went, this works for me.
Yeah.
And she was awesome. She's someone that I have a huge amount of respect for, and she is, if I'm half the surgeon she is, I'll be a very happy person. Now there's, I'm working in a unit where there's multiple women, and that's a real change for me. But apart from that, a lot of the negativity or the people trying to dissuade me from pursuing orthopedics as a career came from outside the orthopedic community.
You didn't feel like within the orthopedic community there was this massive push that it wasn't significant in terms of not getting you involved?
I think it's one of those things that, I know on paper, if you looked at my resume heading into orthopedics and you wiped off my gender on it, I pretty much read like most orthopedic surgeons, so I get that.
So you had very similar kind of pursuits and experiences.
Kind of sporty, kind of academic, ticked a lot of the boxes in that regard. And I just put myself out there. Like, I'm not the smartest, but I'm not the most academic. I haven't written the most papers, but I can show up and I can do the work. And so I showed up every time and did the work.
There's something in that too. And actually it's worth asking you, because you obviously mentioned, you got very heavily involved with gym and things like that. And one of the things that Pam brought up with us was the fact that orthopedics is a very physical, surgical specialty.
Demanding.
Physically demanding. Is that something that you think potentially brings people in or out, and it doesn't matter gender, but it brings people in or out because they're like, oh, actually, this is a very physically demanding pursuit?
Yeah, look, pre-power tools, it would have been absolutely insane. Like,
so if you get the Makita out, you're okay.
Yeah, but power tools have changed things a lot, and if you can get through and survive orthopedic training, you can pick a niche that is not so physically demanding. But you got to get there. And I think, you're absolutely right. The physicality of it, there is, some real challenges posed there. Some operations, I hate to say it, we all say that it's all technique, but you need
some grunt.
You need some grunt, and you need some tenacity and some staying power to get through it. I spent 2 hours trying to get a prosthesis out of a femur, and it was hard work. I've broken mallets. It's in cases, it's nice to think that it is all technique, and it is. But again, bless Lynette as the first female through Newcastle. She's a little shorter than me, and she always says that because, of that, she had to get great technique, but that woman is a powerhouse.
Yeah.
Like, I have huge respect for her athletic capacity as well as her technical expertise.
Is it something that they discuss with you during the training of, like, you actually need to be physically prepared for orthopedics? Like, do they put a gym in the orthopedics training school?
So in the US, yes. In Australia, no. But if the classic thing is we're as strong as an ox and twice as smart. We're known for being a bit stupid, or we try and play that up so that we don't need to manage all the other things going on with our patients. But there is a physically demanding aspect of it. There's no doubt about that.
It actually makes me think, John, with even our own profession are there certain prerequisites that you should have?
The
physical markers. Yeah.
Having said that, there are orthopedic surgeons out there who have achondroplasia. There's orthopedic surgeons out there who are missing digits. There are... there's people who have different sets of abilities, and they're still very capable surgeons. So you can adapt to it. But I spent probably the first 5 years of my training standing on a step, because most of the guys I trained with are 6 foot tall, and I'm sort of 5'6", 5'7". So to be at their level at a table comfortably, I need to stand on a pedestal. So I always joke that I need my pedestal to function these days. But, but in all seriousness, yes, you kind of, and I suspect you find your subspecialty based on your interest and what you feel your body can endure as well, because there is a physical component to it.
Can we delve into some technicality?
Totally.
One of the things that we were super interested in was obviously you do some very complex surgeries, whether it's removal of tumor, as you mentioned, sarcomas, or even limb salvage or amputation. What's actually involved in particularly in one of the questions that Jack, and I talked about was like, the neurovascular structures and how you actually go about, I don't even know what the term is, sorting those out.
Yeah.
Like,
and more broadly, like, because I imagine a lot of this involves effectively changing people's anatomy, where all of a sudden you have to remove a muscle, and therefore you think, okay, how does that influence the mechanics of affected joints?
Yep.
And what do I do then to potentially replace that? Do I move this muscle to here to then act as an extensor or versus a flexor, whatever it may be?
Yeah, in general, like what is the way you approach that of, okay, I'm doing this. What are the structures I actually need to make sure that I've ticked off that are actually functioning at the level to make this useful?
So again, I mean, to use a catchphrase, bespoke surgery, like if the tumor is or infection or whatever is in a spot and I need to sacrifice something, I will. You try really hard to preserve important structures like neurovascular structures, because obviously if you don't have plumbing to a limb to provide blood, that limb doesn't survive.
Can you explain on the technical side, like what do you do? Say, for instance, okay, you're about to remove, let's use an example maybe. Is there something, a case, you don't have to use obviously any of the major details, but a case of something that you've removed recently and what actually you had to do with those neurovascular structures?
So, I mean, two cases come to mind pretty quickly because I've done a few that have been a bit interesting lately. Like I had one patient where their tumor was stuck to their femoral artery.
Okay.
Which
That's
is
very interesting.
So we couldn't tell, you can't tell when you're doing this surgery at the time whether the tumor has invaded or whether it's a repercussion of the radiation treatment that you've given them. But their type of tumor and all these things made us highly suspicious. And if it's stuck, I can't just say, oh, it's probably radiation and leave tumor behind. I have to make a decision. And I'd known that this was the case. So I had vascular surgery with me. So they're there to help me out because I can make tumor decisions and I'm good at doing musculoskeletal things. But if I'm going to cut major arteries, that's not my specialty. I can cut it, but I can't reconstruct it. Or I can, but I'm not the right person to. Like fundamentally, I know how to do it. Fundamentally, I can fix an artery or a vein. But when it comes to one that has a name that supplies a whole limb, you've got to be crazy when there's people who've spent 20 years studying how to
that's
do it.
Their area. That's their area. Let them do their job.
Let them be brilliant at what they do. So, we sacrificed, maybe 15 centimeters of this patient's femoral artery and vein. So you're now on the clock once you stop that blood flow to that limb. And that means I've got to get the tumor out quickly or as quickly as I can possible, and safely, sacrificing some muscle and stuff around it, and then let the vascular surgeon, they've got a team harvesting a vein from the other leg at the same time so that they can then plumb it in within the 4 hours that we've got window of opportunity to reperfuse this limb before it starts to die. So, you are under the pump at some level, but also you want to have the right people around you who know how to do this. And for them, it's like, okay, cool, we got this. And I think that's one of those key things, and having that nice calm vibe in your theatre so that you only peak your blood pressure every so often. And then
when you do remove, say, muscle tissue, are you thinking about, okay, I think this is now going to mean that they can function in this way, or are you understanding I can remove this and it's not going to have too much issue with function?
So there's twofold parts to that. One is there's a phrase that we say, which is tumor made me do it. I will always go for...
That's a great phrase.
Yeah.
I'm going to say that as well when I behave weirdly. Oh, the tumor made me do it.
Yeah. Like the tumor defined, like good tumor care means I have to know how much I have to take margin-wise and things like that. I will sacrifice something really important if I have to give someone the best longevity of life that I can, right? Because I've got to think
hierarchy
about that.
Is more important.
Yeah. So like the other day I took someone's sciatic nerve.
Which you do with it?
Yeah. It got sent off with the tumor.
Yeah.
So, but the thing was, I looked at the imaging. It looked like it may be involved, but maybe not. And actually, because the tumor was so big, it had split off part of it. So because as you guys are probably well aware, and just for the people listening, there's two major parts to your sciatic nerve. tibial part and the common perineal part. So the common perineal part had actually been pushed off as a completely separate bundle, so I could completely save that. And then I had this 2-part of the tibial one, because the nerve it's like cabling for electricity, right? It's not just one big nerve, it's all the nerve fibers doing different things. So I worked out where we would need to cut it, and then we test it to see which part is innervating what, because we are going to go for motor over sensation.
Yes.
Right? So I get the plastic surgeons to come along because they're the geniuses at reconstructing nerves. And I'm trying to minimize the amount of nerve I take so that they can reconstruct it by borrowing nerve from somewhere else and doing a cable graft. So I did a step cut so they could work out which side was innervating what. And so we make that decision together.
This is so impressive, and it's really interesting to hear this.
And the thing that I'm interested to understand too is, how responsive or adaptable are people to doing this? Like when you say take a nerve out and use a graft, or if you cut a muscle out, how do you find it amazing how adaptive the body is when people actually recover and
hugely
restore movement?
Yeah, people continue to astound me with what they are capable of achieving after some of the things that we inflict upon them as surgeons. You know, like someone pulls a hamstring and it feels like they're so like debilitated. And I don't take that lightly because I've recently repaired more than a handful of them, which was not fun for them or me. But in all seriousness, like when you're finessing things in people with high demand, it is incredible, you know, but then you do these surgeries that you just think, I don't even know how you get through this as a person. Like I get to do things and people give me the grace to do and the faith in me to do these things that you sort of think, how does this work? And then they just continue to astound you. You know, I have patients who we've taken their entire scapula out and they've got full function.
Yeah, wow.
You know, there was a guy that I had the privilege of looking after in London who sequentially over the years had ended up having his entire femur replaced with metal. And some of it was self-inflicted because he likes to ride his mountain bike around the streets of London. You know, and I'm at that. People go, "Oh, you got to tell him he can't do stuff." And I'm like, "But we've done this so that he can live. He is living his very best version of his life, and that involves bashing down 500 steps at St. Paul's Cathedral in the middle of the night. What was the point of operating on him if it wasn't, to give him a limb that he can do fun stuff with? So I'm happy for my patients to push the envelope and show me what they can do. And some of them just like each person. There's probably a psychosocial component to it. There's that, the highly motivated ones just do so well. People who struggle with body image and things like that tend to struggle a little bit more to retain that function. But the ones that really go for it, they amaze me.
I was going to say, do you find that you can start to profile people in terms of how adaptive they will be following surgery? Yeah, like, use the example of someone who it's a self-inflicted injury because they like to do quite extreme sports or physical activity. They're motivated to get back to doing what they want to do, and you see a much better response in those individuals.
You often do. I mean, some of it is just going to be the luck of the draw. You can do the best surgery in the world and you have a complication that's just devastating and it can ruin someone's life. But the flip side is you can do things that you think, I'll be really happy if this patient gets up and can walk with crutches. And they can't. I had one walk into my room and he's like, it feels like a normal knee. And I'm like, I cut 20 centimeters of your femur out 6 weeks ago. I was going to say, you should not feel normal.
Yeah. Do you find you're constantly thinking, well, that worked out a lot better than I thought it would?
Yeah. I mean, I'm a disaster planner. I'm a disaster plasty surgeon. I plan for the worst and hope for the best. You go in there knowing that it could just all be really hard, but you throw down the best that you've got every day, for your patients, and you try and give them the best possible outcome that you can with what you've got to work with. But sometimes it's, you have to explain to them that we're going into a pretty risky or multiply operated limb. Like, I'm not going to give you back what you had when you were 18. I'm going to give you something that will let you hopefully get around your house independently. Maybe you don't need the 4-wheelie walker in the house. Maybe you need it when you go out. Like, your goals of care are very different, and I'm very upfront with them about what the risks are.
A question we've actually asked a few surgeons is around development of certain technologies or like regenerative medicine, which I imagine is very relevant for what you do. It's interesting though, because a lot of the time it seems that the response we get is like, there's not really much out there. But then the thing that I always notice is you read blogs or you listen to podcasts and people are always talking about, I got this stem cell therapy in some jurisdiction where there's basically no regulation and it completely fixed their knee that had, they always use bone on bone, which there seems to be a bit of a contradiction here, because it seems that in the mainstream medicine in developed countries where there's a lot of regulation about what you can and cannot do, there's not a lot of advancements. But then in places where it's a bit like the Wild West and you can try lots of different things, seems to be some amazing breakthroughs. What do you see, or what do you know about this area, and whether you think there's some pretty interesting and innovative stuff coming on the horizon?
Yeah, look, I mean, certainly in some of the things I do, there's some pretty interesting things going on. We're deep into the world of custom prostheses for patients, where we customize it for their tumor and reconstruction and things. And, there's complications that come with that and all sorts of things. And we're looking at different materials, how we can integrate native bone. We do things where we use donor bone and try and get your body to integrate that. What can we use that helps encourage that to happen? So that for me is sort of where the cutting edge of stuff is. The difficulty being most of the things that encourage bone growth from a chemical point of view also increase your risk of bone cancer, which when you're cutting bone cancer out,
doesn't make
sense.
That's
a hard sell. I can put this really cool, expensive product in there, but there's a theoretical risk it increases your risk of osteosarcoma that I just cut out of you. That's a really hard sell. But, looking at things that can improve, it's always marginal gains. And I think anything that sounds like a big leap forward that's coming out of one of those uncontrolled jurisdictions, it's like, show me the paper trail.
This is probably where, you think about evidence bases, we probably do need some research to guide what we do, as opposed to just, hit and miss.
Science is a philosophy of how you observe things, right? Like if we take it back to its core values. So it's not about having the biggest, speckiest paper, but saying a friend of my cousin's aunt's third,
Dog.
had bone-on-bone arthritis, had this injection done, and they've never had pain again. Well, some people's arthritis is not it's arthrosis. It's not arthritis. If you want to get into the semantics of inflammation. So maybe what they did settled their inflammation down. Maybe it was the natural history of theirs, because it is a relapsing remitting disease. Did they just spend an awful lot of money, and so now that's massive placebo or or it was massively painful, so a nocebo effect. There's all of these layers to it, or are they just talking rubbish because there's some sort of gain for them in that?
Well, and look, I guess there's always the case of N equals 1 of this person did this and they had a great outcome, and I think that's where the value of research lies, because it's like, well, look, on average, we do see a certain effect, and it reduces some level of uncertainty about whether it may or may not have an effect.
Yeah. And look, you're talking to someone who, I understand that, say, like lumbar back pain, right? Physio doesn't fix lumbar back pain, but it helps people cope with the pain and then allow them to rehabilitate. Now, some people will say that means that it doesn't work, whereas I look at it as that's a tool for facilitating this. There are things that I do that are designed to be tools to facilitate something else. And I think, but people need to be upfront about that. This is not a silver bullet. This is not going to cure this. And anything that sounds too good to be true probably is.
It's actually a good way to put it, actually, where you think of, even from your side, where I think people probably would associate orthopedic surgeons as you're going to fix me, but it's actually, well, I'm kind of just remodeling the mechanics and the anatomy to allow you to function at a certain level. It's probably even a good way of how we can think of it too, of you actually building up capacity to allow some type of remodeling of how someone can function physically.
Yeah, definitely.
I fixed a gentleman's shoulder the other day, and I always explain to people, my job is to put those fracture fragments, those bones, back where they belong, to give you the best chance of a good functional outcome. I provide the scaffolding. I'm a carpenter. I am building you something that...
Or a barber, specifically.
Or a barber, exactly. But my job is to put it where it needs to be for you to heal it and then get on with life. I don't heal the bone. You do that. I put it where it is, and then you do all the hard work. It's an understanding that my job is to facilitate moving someone into a better place in life. It's not actually me doing it.
Typically, we like to ask people something that they are exploring in their own interests, because we tend to find that, like yourself, you seem like a very curious person.
And you probably got lots of spare time outside of your work and
Heaps.
family.
Yeah.
So,
But just something that's it's an idea or an area of interest that's kind of taking up some of your time, that it might be something you work on regularly, or it might be something that comes along every now and then, but it's an idea that's kind of been squirreling away in your brain.
Oh, look, I could try and say something really smart. I don't really have anything really smart to say.
That's okay.
My latest thing, and this is courtesy of my other half, my Christmas present is my Whoop. And so I thought that was kind of pertinent. Insofar as I'm really interested in sort of our physiology and our like stress responses and working out what actually, because people go, oh, what you do must be really stressful. So it's like, well, is it? What impact?
If so, how? Yeah.
If so, how? What impact does, a really big day operating have on my stress strain? How does that affect my sleep? I mean, I am a self-confessed caffeine addict. I don't think there's ever going to be a day where I have no caffeine. So I don't know how that's going to play out with my data collection. But I mean, I love data. I love feedback. I'm a sucker for it. I've worked through, macro and micro cycles. I've worked through if it fits your macros eating, like all of those influences. And I am also very interested in how me having that feedback loop affects what I actually choose to do.
Yeah.
Because the accountability is huge for me. So I'm really interested in like how that all interdigitates into each other.
It's interesting to say that, like as I said, I'm involved heavily in sport, and I've been getting into a number of kind of discussions, and on my end, usually disagreements, because I feel like one of the things that's becoming really popular in the exercise science, physiology thing, everyone's so caught up in recovery. They're not really thinking, it's almost like they're more worried about recovering than actually doing anything that stresses you, which doesn't really make sense, because your whole job is to keep adding stress. And one of the things that I'm really interested in, and I can't seem to get a great answer on, is actually being able to quantify, as you said, like mental or cognitive stresses and how well you can adapt to those. Like I would say, for instance, and you already mentioned this, say with being a parent, I'm sure you actually have greater mental and cognitive, bandwidth now than what you did before you had kids, because you already had developed a lot of that through your studies, through your, your work, through your surgery. And now you've actually had another cognitive load placed on that. And the difference in the development of that over time, all the answers I get back of, we don't really know. We haven't been able to see, like, okay, Sarah was here with how much, say, cognitive load she could take.
Yeah.
Now she's actually here, and you use something like your Whoop or whatever it is, and it's like, oh, before when I did 12-hour days and I had my kids and I did this, my strain score was 2, and now, it was really high, and now it's gone down to 2. Correct. And it's like, oh, I'm actually dealing with those stresses really easily because I've adapted. I can't seem to get an answer from anyone, because it seems like they haven't really looked at that capacity development.
Yeah, totally. And I think that's one of those hard things that when you look at you're right, everyone's obsessed with recovery. I think recovery is really important, but our bodies respond to stress and strain, right? Bones remodel according to the stresses you put through them. Like that, I'm an orthopod, I love bones. Sorry. It's how it is.
I love bones.
I love bones.
You should put that on your social media.
Oh, I think I have at various points. In fact, if you find me on Instagram, I'm pretty sure it just says that,
I love bones.
I love bones. But, it's one of these things that our bodies respond so well to stress. And then you think about it from a psychological point of view, how you navigate that, because obviously if you have too much stress, it's a bad thing, and too much cognitive load is a bad thing. But also, can you build that resilience over time?
I think you definitely can.
Yeah,
is
you've
the
got
answer.
to be able to.
Well, like, even if we think, I think all of us, and we're probably all of similar-ish age, if you think back to 10, 15 years ago, how much, even if it was just professionally, how much work you could take on, there's no way that 15 years ago I could do what I'm doing now and not be stressed out of my eyeballs, right?
And particularly figuring out the things that you need to do around your lifestyle to be able to support your ability to function at a high level too. Yeah, that's the other really big element that you figure out. Yeah,
and I think finding the things, like for me, there's not a lot of hours in the day. I know everyone talks about having the same 24 hours. Yeah, good luck. When I hear, just get up at 5 to train, I'm like, but I'm already up at 5.
Yeah.
Like, I'm doing stuff then. I start meetings at 6:30 in the morning. But how do you find those little pockets of time, and how do you optimize them for your recovery and so that you can add to that strain that you've got? I've discovered that there's a particular meeting that I sit in that my physiology does not like that meeting.
So do you not go?
I go under duress. But I look at it and I'm like, that's interesting. the highest peak I had was I did a morning of operating and I hadn't had breakfast and I was fine when I was operating. And in the private sector, they're really lovely. They will order lunch for you, right? Which is beautiful. So there should have been a burger waiting for me in the tea room and someone stole it. I can tell you now, I hit maximal stress and then it dropped to minimal when I picked up my sushi on my way to clinic.
Interesting.
And it's like, I love food, so that's fine. But I just thought it was really hilarious that, like, of all of the things that I had done that day, I can operate on a person, and I'm like, that's cool. You took my burger,
and now I'm stressed.
Stressed. You know, it's like we are just animals, right?
Yeah.
Like someone's taken my food source. This is not good.
That's so funny. We want to thank you so much for taking the time. It's actually been probably one of our better podcasts ever, I think. So thank you very much for your willingness to share your knowledge so freely and so openly and in such a humble way. Where can people find you if they do want to learn anything from you or get in contact?
Seek your assistance.
Yeah, seek your assistance to have their limb salvaged.
Please. I hope there's not too many of you out there. Look, there's a number of places. My public practice is at St Vincent's Public, and that's where I do my sarcoma work. I have a private practice at Victoria Bone and Joint, which is also co-located in Fitzroy, and we have rooms in Knox.
Mm-hmm.
Social media-wise, I am on Instagram as, I think, Dr. SOH, and I am Squats and Scalpels on Twitter, which is now known as X, which is mostly me waxing lyrically about all things orthopedic.
Fantastic.
That's sort of like where my homies are.
Please make sure you do follow and get in contact if you do need anything. But Sarah, thank you so much.
Such a privilege, and thank you for asking me along.